Good morning, good afternoon, and good evening, everybody. It gives me a great pleasure to start the first scientific session of this successful Congress, the 15th Miyako Congress, in association with the Second International Glaucoma Congress. I'd like to welcome and thank you all, especially our distinguished speaker in this session for their scientific contribution. And they're coming from all over the world. They're coming from Australia, from the USA, and from our region in here, Middle East, MENA, and also from Asia. And a warm welcome to my friend and co-moderator, Dr. Samir Al-Mulki, who is the president of the Jordanian Ophthalmic Society, who did host the last Miyako meeting in person in Amman in Dead Sea last 2019. We start our lecture with Professor Ken Nischel. I don't think Ken needs any introduction, but he's the vice chair and chief medical ophthalmology in the University of Pittsburgh School of Medicine. And he's a co-founder of Society of Pediatric Ophthalmology and Strabismus. And we have a good part in this session from the WISPOS. I'm myself a member of the scientific bureau, and the Professor Nischel is a co-founder, and we have also two scientific members, Dr. Siwi Liu and Dr. Lionel Coel. So I leave the podium now to our co-moderator, Dr. Samir Mulki, who will just introduce the rest of the speakers. Dr. Mulki.
Right. Now, we have actually a number of eminent pediatric ophthalmologists this will include 7 talks by a number of eminent doctors in their fields of specialty. So we will start by Professor Ken Nischel from the US. Dr. Ken.
Thank you, Miyako, for asking me to speak today at the Miyako 2021 virtual meeting. I'd like to talk about the safe pediatric cataract surgery technique, which I've called SPECS. These are my disclosures, none of them really relevant to this particular talk. And I'm also the executive co-director of the charity WSPOS. These are all the things that we normally think about when we talk about pediatric cataract surgery, but for the sake of time and to really hone down onto what I think are the safe principles of pediatric cataract surgery, I'd like to talk about the 6-point plan: anesthesia, wound site and closure, capsule management, lens aspiration technique, intraocular lens type, and in-the-bag placement of the IOL if possible. Anesthesia is important, and it's important because I like all my children to be paralyzed. And I like them to be paralyzed because that way the eye doesn't move, the eye is looking up. If you use a traction suture like the one shown here, in children who are young, because the sclera is elastic, you transmit a force to the vitreous base that distorts the anatomy and makes your surgery more difficult and more prone to iris prolapse and vitreous loss. I like the CO2, the end-tidal CO2, to be low because when it's high, there's more positive vitreous pressure. All of these things help to reduce iris prolapse, which helps to reduce the incidence of inflammation and secondary complications later on. What about wound site? I like the wound site to be on the temporal side because that way there's less distortion if I'm implanting. If I'm doing a lensectomy, it doesn't matter where my wounds are, they're small and I don't mind. But if I'm putting an implant in, I like to sit temporally and go through so I'm not turning the eye as I put the implant in. I like the wound to be limbal corneal because I do not want to disrupt the conjunctiva. Why? Because we know violation of the conjunctiva increases the risk of failure of any glaucoma drainage procedure that might need to be done in the future. The younger the child, the greater that risk. I like to close all the wounds with tenovicryl. Why? Because the elastic sclera can end up with a gaping wound, even if it's a small wound. And if that happens, you get increased fibrin, shallow AC, peripheral anterior synechiae. It's not worth it. It's important to close it. The suture dissolves, and many groups have shown that the amount of astigmatism induced by tenovicryl is negligible. Capsule management. I like to use a technique, whichever one you use, that is consistent, repeatable, and reliable. There's the manual capsulorhexis technique. The problem with that is that there's a learning curve, and I don't want children to suffer because of my learning curve. Vitrectorhexis is popular. The Ertley or the diathermy system is popular. However, I don't believe they're as robust in my hands as the manual capsulorhexis technique or the 2-incision push-pull rhexis that I described almost 20 years ago. I described that because I wanted the opening of the capsulorhexis to be smaller than the optic of the lens, and I'll explain why in a minute. So as I said, you choose a technique that's consistent, reliable, and repeatable. I decided to use the 2-incision push-pull capsulorhexis. Why? Because I want the opening to be smaller than the optic. If the opening is bigger than the optic, when children rub their eyes, and they do it all the time, they trampoline the anterior chamber, and they can cause forward movement of the lens compared to the iris, and you get lens iris capture. And once this happens, it's a problem. You're going to get chronic inflammation, and it's very difficult to put this lens back. So the 2-incision push-pull rhexis was described and published 20 years ago. And then there was a follow-up study done by my group, basically showing that we got very reliable outcomes in children aged from 4 weeks to 18 years. So these papers are available to look at. The paper in Ophthalmology, which is the one on your right, also has a video with it. There's a video on the YouTube channel, the Ken Nischel YouTube channel, which has a 4-minute narrated video telling you how to do the 2-incision push-pull rhexis. Briefly, the younger the child, definitely under the age of 3, you can do 2 stabs, which is the diameter that you want of your opening. You just push and you pull. And because it's so elastic, the capsule, you get this round circle. Now, this is a child who is 4 months old, and you'll see that I'm going to do 2 stab incisions. I use the calipers to give me a rough idea. I normally aim for 4.5 because it can get a little bit bigger. My optic size is normally 6 millimeters, so I want something that's around 5 millimeters. Now, when you go in, try not to push down because you'll get a V pattern of your stab. You want a slit as a stab. Having done that, I use I don't like to open the wounds very much. I'm using a capsulorhexis forceps that's a micro capsulorhexis forceps, and I'm pushing, and then I'm going to pull. Now, what often happens is that one half is a little bit bigger than the other, and all you do under those circumstances is to use the smaller one to finish off your rhexis. So here I'm just pulling now, and you can see here the edge of the rhexis. And once you push and you pull, and as I said, where it doesn't quite meet, you just get the edges to meet. Now, I'm going to show the lens aspiration technique, although I'm going to talk about it later. And what I want to point out here is once the capsulorhexis is done, it's much easier to have the confidence that the rhexis is robust. Whereas if you've done vitrectorhexis or if you've done radiofrequency diathermy, that confidence is lower. It doesn't matter if you're not going to put an implant in. Now, I want you to notice something. Even though I can see the posterior capsule is intact here, I am removing the peripheral lens matter first. And I'm doing that because I want my muscle memory and my surgical technique to allow me to do that. So when I have to do it, it's not so much of a problem. And I'll show you a case later when you have to do it. So sometimes if in older children, normally over the age of 4, when you do your 2 stabs and you push and pull, you get an oval opening. And so you have to do this in stages. And here's a video of that. I've made my 2 stabs, as you can see, and I'm increasing the size of 1 stab. And then what I'm going to do is I'm going to take one side and I'm going to push. I'm taking it there. I'm going to push to the left. And then in a minute, I'll go to the distal stab and pull to the right. So I'm actually sort of doing this kind of maneuver like that. Now, the issue is that in older children, I worry that my initial stabs may be a weak point in the rexis. So what I tend to do is when I make the tears, I actually include my initial stab. So you'll see me here pulling on the capsule. And it comes all the way around. And bingo. And then the other one, I do the same thing to include the tear. I think that's very important to remember to do that. In younger children under the age of 3, you don't normally need to do that. I have found that not necessary. So that's done. Okay. So what I want to show you is after you put the lens in the bag, this is how it should look. You know, the optic should be well away from the pupil margin. In my hands, children under the age 4 or under get a posterior capsulorhexis and anti-vitrectomy. Children over the age of 4, even up to the age of 18, depending on, you know, what their cooperation is like, I like to do a posterior rhexis without disrupting the anterior hyaloid face. In order to do that, you have to inflate burger space. And this is a nice picture because it shows after you remove the lens matter at the bottom here, the posterior capsule wants to bulge forward. And you've got to inflate that bag a little bit to push it back so you can do your rhexis. So here I am, I'm doing my 2 stabs. Now the opening for the posterior capsule is smaller than the anterior capsule. I'm now going to inflate burger space with viscoelastic. And then what I'm going to do is I'm going to do a push and pull technique so that I can do my posterior rhexis. Now, don't worry if there's a plaque, because what happens is the tear works along the plaque. So the plaque almost acts like a template. With plaques, be aware that the posterior capsule often looks like it's multi-layered. You've got to make sure you're getting all of the layers. Otherwise, you'll be ending up with a very fine film, and you'll wonder why there's visual axis opacification. In this child's case, actually, I think I did an anterior vitrectomy as well because the child was 3 years old. So the 2-incision push-pull rhexis, again, very comfortably done on the posterior capsule as well. Sometimes there's a posterior polar cataract. You can see that here. And you can see on the OCT that there's a breach of the capsule. And once I've taken the lens material out, and I took it out in the way that I mentioned, you know, with the nucleus being taken out last, there's that knuckle of vitreous, and you have to be aware of that when you do your posterior rhexis. So my lens removal is lens aspiration, always, never any phacoemulsification, never had to do that. Here is a child who has a white cataract. Remember what I said, there may be a posterior defect here. So what I'm going to do now is, as always, remove the peripheral lens matter before I remove the capsule itself. And when you do that, you'll see here that at the end, when I remove that nucleus, there is a defect in the posterior capsule. Now, if you remove the nuclear part, the central part first, and you still have your peripheral lens matter left, when you try to aspirate that, you could be tugging on vitreous, which could be transmitting that force to the vitreous base, which could lead to retinal tears. And that's why it's important to learn to take the a peripheral lens matter out first, followed by the nucleus. And you see here that when I come to remove the nucleus, there will be a large opening. And that opening, hopefully we'll see in a second. I can take the lens material now. Here it goes. And there is indeed a large defect, which you can see in a second, just there. Okay, so whenever possible, for these citations here as being some reasons why I try to avoid putting a lens in the sulcus in younger children. Sometimes you have to do it, but you have to be aware of what might happen. And here is a child who had a lens put in the sulcus, sent to me for second opinion. You can see how the iris root is being pushed forward. And this can be seen fairly regularly. So you've got to be careful. But I accept that sometimes you have no choice. Place it in the bag if you can. Now, what I want to show you here is after you inflate the bag, which I'm about to do now, and you do your posterior rhexis, the flaps of the posterior capsule are pointing downwards because of the elasticity. So when you put a lens in and there's a posterior opening that you've made, don't rotate the lens, otherwise it will go down south. So here I want to show you that the posterior opening is bigger than the anterior opening. I'm using a 3-piece lens. Why? I always use a 3-piece lens because if I have to put it in the sulcus, I know it's not going to decenter. And also, if I have to do optic capture, I can do that with a 3-piece, not with a 1-piece. Now, I've put the haptic in the bag. I'm going to pop the optic into the bag. And then what I'm going to do is I'm going to place the trailing haptic. Always place the trailing haptic. Do not rotate this lens. Because if you do, that leading haptic could pop down. Remember, I showed you the ledges of the posterior capsule are pointing down like that. So I'm going to use a McPherson lens. Going to go in, rotate my hand, and place it in the bag, like so. When you remove the viscoelastic, you've got to be very careful that you close the wounds. You bring your bottle height down so you don't put too much pressure. As I said to you, I use a 3-piece lens for all the reasons I've said, because I think it's the safest way of doing it. So my 6-point plan: anesthesia, wound site enclosure, capsule management, lens aspiration technique, intraocular lens type, and if possible, in the bag placement. Thank you so much. These are my YouTube channels that I'm affiliated with and my Twitter handle. I appreciate very much the opportunity to speak to you. Thank you. I think your question, Mohammed, was, do I use Vision Blue? I don't use Vision Blue unless it's a totally white cataract and I can't see the capsule. I know some people use Vision Blue regularly, especially for the posterior capsule, but with the 2-incision push-pull, the posterior capsular rhexis becomes very, very easy to do. But yeah, if you want to use Vision Blue, I don't think there's any harm. It becomes less elastic, which is helpful too. But I don't use it regularly, only if it's a totally white cataract.
Actually, I like the idea of just putting the IOL in the bag if we can, but you know, in pediatrics, so this is not easily done all the time.
No, I agree with you, but I'm saying that I think it's the techniques. You know, people have been put off by putting the lens in the bag because so now that we have intraoperative OCT integrated, we can understand why we ran into the problems that we ran into. You know, in an adult, if you do a posterior rhexis, the capsule remains like that, but in a child it does this. Once you know that, you're never going to rotate the lens in, because you know it's going to be a problem.
Yeah.
So placing the lens is much better, and it takes a little while for the fellows who work with me to get used to that, but once they do, they're very comfortable in doing it.
And at what age you stop just doing the posterior capsular axis and anterior vitrectomy?
So posterior axis and anterior vitrectomy, once they're 5, so up until the age of 4 and include the year of 4. But after that, I will do a posterior axis because I'm comfortable that I'm not going to disrupt the anterior hyaloid face up to 18 years of age, depending on the child's behavior, etc. You know, people say once they're 8 that it's very easy to do a YAG capsulotomy. I don't think it is. Maybe it's just the children that I deal with. But doing a YAG capsulotomy on a 10-year-old is not an easy thing to do necessarily. So yeah, I do a posterior axis all the way into the teens.
Thank you very much. Samir, do you have anything, or any of the speakers? You have any question just to address to Professor Nishal?
Yeah, Ken, if I may, what's your preferred formula for calculating IOLs in children?
Excellent question.
That's a good question. So if the child is under the age of 4, the axial length is normally 20 or below, or 21 or below. I use the Hoffer Q, but I customize it. So I measure the anterior chamber depth, and then I do a predictive anterior chamber depth, knowing that, you know, what my lens thickness is of my IOL. And I find that to be helpful. Otherwise, I use the SRKT formula.
Right.
And do you think just the anterior posterior diameter is just a key for just inserting an IOL in children? If it is small?
No, I think the key to inserting a lens, firstly, is the size of the eye. So the axial length does matter. But I think the more important thing is some people worry about the corneal diameter. I worry more about the lens, the capsular lens diameter. So you can measure the crystalline lens diameter and add 1 millimeter. And as long as it's more than 8 millimeters, you should be able to get a 12.5 or 13 millimeter foldable lens into the bag very easily. If you want to measure the lens diameter, use a linear ultrasound. Those of you who operate in hospitals, all your anesthesia departments have a linear ultrasound that they use to find veins, and you can momentarily put that on the eye, and you can actually get a nice picture of what the lens diameter is. You just measure that and add 1 millimeter.
Excellent. Excellent.
Yeah, I have one question. Can I ask one question, please?
Sure.
So, Dr. Ken, do you prefer for IOL in the back, do you prefer anterior approach, posterior capsulotomy, or posterior approach? So which one is better, you think?
So in my hands, I do everything from the front. Now, I have stopped implanting children under the age of 3 months. They're normally unilateral cases, and I found that they have PHPV, so I don't tend to do those. But when I implant a child of 6 months or 5 months, I still do everything from the front. I used to, when I was implanting children around 2 months of age, put the lens in the bag, close the eye, and then do a pars plicata. But I don't need to do that anymore because I do the older children. And you know that the important thing to remember is that a unilateral cataract is different to bilateral infantile cataracts. Bilateral infantile cataracts are often due to crystalline gene mutations, and the eye size and the eye behavior is different to unilateral cataracts that are often due to PHPV or persistent fetal vasculature.
Thank you.
Thank you again. Thank you very much. I think we're running out of time. We just ask Professor Arif Khan now from Cleveland Clinic, Abu Dhabi. I think Dr. Khan does not need any introduction. Also, he's a world-known pediatric ophthalmologist with interest in ophthalmic genetics, and he will talk about pediatric glaucoma diagnosis we cannot afford to miss. Professor Arif Khan, thank you.
Greetings from Abu Dhabi. It's my pleasure to be part of Miyako 2021 Virtual. Thank you to the organizers for putting this meeting together and for asking me to participate. My presentation is about a glaucoma diagnosis we should not miss. So here's a 3-month-old boy referred for glaucoma surgery. He has tearing, photophobia. He has pressure of approximately 40 in either eye. He's got large corneas that are hazy. He's got a myopic reflex, although difficult to quantitate. And it's difficult to see the posterior pole. Before bringing a child like this to the OR, I prefer to get a better exam as an outpatient. So I put him on some anti-glaucoma drops and had the family come back in a few days. To my surprise, when they came back, the child was much more comfortable. The corneas were clearer. Despite the size of the corneas, there was no haepstria. The IOP was low. Fundus was not myopic, even though the refraction was -27, -26 in either eye, and there was no significant cupping. So what's going on here? Well, this child never had primary congenital glaucoma. This child has a primary megalocornea, that is a primary megalocornea not related to increased intraocular pressure, with zonular weakness and a tendency for the lens to move anteriorly and cause pupillary block and a lens-related glaucoma. This patient has a unique phenotype that we see in the region, LTBB2-related congenital megalocornea with zonular weakness and secondary lens-induced glaucoma. This is an important condition to recognize because the treatment for this is lens removal. It is not angle surgery. In fact, angle surgery can be disastrous in these children. Now that he is more comfortable, here we can see in an image from one of his eyes that he has actually some lens subluxation. There's actually 360 degrees zonular weakness. Again, look at the size of this cornea, more than 13 millimeters, with no haepstria. This is a primary megalocornea. So LTBB2-related congenital megalocornea with zonular weakness causes a secondary lens-related glaucoma. Primary management is removal of the lenses. Angle surgery is very bad for these children. Here's a few words. I wanted to say a few words about LTBB2 and primary congenital glaucoma, because it's in the literature that LTBB2 is a primary congenital glaucoma gene. But this is a bit misleading, and it's inaccurate to an extent. LTBB2 started to be written about as a primary congenital glaucoma gene back in 2009, based on a few Pakistani, European Gypsy, and Iranian families that had been diagnosed as primary congenital glaucoma, but were negative for CYP1B1 mutations. Of course, CYP1B1 mutations are the major cause for primary congenital glaucoma, the major identifiable cause for primary congenital glaucoma, especially in this region. These families underwent further genetic analysis, and it was found that they had mutations in the gene LTBB2, and thus LTBB2 was labeled as a primary congenital glaucoma gene. However, you go back and you look at these papers more carefully, many of the patients were only phenotyped later in life, at which time they had corneal scarring and advanced disease and end-stage disease. It was just assumed that they had had primary congenital glaucoma. It wasn't really, they weren't seen during their presentation in childhood by the investigators. In addition, many of the children from these papers had ectopia lentis or had had lens surgery to remove the lens in childhood, and almost all of them responded very poorly to angle surgeries that had been done. This is strong evidence that the patients in these papers, the families in these papers, actually had congenital megalocornea with zonular weakness and secondary lens-related glaucoma rather than primary congenital glaucoma. I can tell you that none of the LTBB2 patients that I've seen have had primary congenital glaucoma. And I can tell you that our cohort and many other cohorts of primary congenital glaucoma patients who are negative for CYP1B1 mutations do not have LTBP2 mutations. Again, when we look in the region, most of the patients in the region with primary congenital glaucoma have CYP1B1 mutations, but the rare patients that are CYP1B1 negative do not have LTBP2 mutations in the many studies that have been done. This is the first family I encountered with this diagnosis. This child actually was not operated on by me. He was diagnosed by the attending physician with primary congenital glaucoma and severe buphthalmus. And for this reason, the attending physician opted for primary Ahmed valve implantation. I'm not saying I agree with that reasoning, but that was his reasoning. So he had primary Ahmed glaucoma valve implantation in both eyes. 1 month later, the child came in with bilateral retinal detachment and bilateral lens luxation in the posterior cavity. Again, what was needed for this child was for the lenses to be removed, not for any type of glaucoma surgery for primary congenital glaucoma. This child came in with the lens in the anterior chamber. You can see right here, the lens is in the anterior chamber here. There's also some lens subluxation in this eye, which may be difficult to see in the photograph, but it's there. Look also at the size of those corneas. This is the LTBP2 phenotype. Now, when a child presents with lens luxation into the anterior chamber, causing an acute glaucoma, very high on the differential diagnosis is homocystinuria. But LTBP2 mutations can also cause this to happen. And what distinguishes LTBP2 mutations from homocystinuria in this regard is that it occurs at a much younger age. This child is 4 years old when it's happening. I think the youngest I've ever seen that it happened in homocystinuria maybe is 7 or 8 years old. The second distinguishing feature is the size of the cornea. Again, look at the size of these corneas. LTBP2 mutations. This child came in at about 1 year old with the lens in the anterior chamber, an acute glaucoma presentation. Again, look at the size of the cornea. Again, the age of this child. This is the LTBP2 phenotype. We found out that his younger brother was scheduled for glaucoma surgery. So we called him in for evaluation emergently. And when we examined him, sure enough, he actually had the LTBP2 phenotype as well. And we were able to avert him undergoing angle surgery, which would have been very bad for this child. I'd like to go back now to the first case that I presented. Remember this child who came in with the pressure about 40 in both eyes? The pressure broke, the pupillary block broke with anti-glaucoma medications. He has -26 refraction, but that's because of lenticular myopia. I explained the situation to the family. I actually spent a lot of time with them explaining that the lenses need to come out and schedule the child for lensectomies. Unfortunately, the family went elsewhere. They actually came back 2 years later, just recently, a few months ago. In the interim, the child has had several failed glaucoma surgeries in both eyes. Most recently, someone decided to take out the lenses in both eyes. His IOPs now are high consistently, despite multiple anti-glaucoma medications. The right eye, the pupil is tonic. There's ectropion uvei, completely cupped nerve, and a +450 aphakic refraction reflecting the long axial length of this eye. The left eye also has ectropion uvei. I see ectropion uvei in these patients. I think it's related to the anterior lens movement somehow stimulating that to happen. He's now got 0.8 vertical cupping in this eye, his only useful eye right now. He's got an aphakic refraction of about +10. This is really a tragic story, but hopefully by raising awareness of this diagnosis, stories like this will be less likely to happen. So in summary, those of us who take care of children with pediatric glaucoma in the region need to recognize the LTBB2-related congenital megalocornea with zonular weakness phenotype is a glaucoma diagnosis we should not miss. These children need the lenses to come out. We take the lenses out early, we can actually prevent glaucoma. I've seen that in many cases. Doing angle surgery in these children, treating them as primary congenital glaucoma, is disastrous. Thank you for your attention. Again, thank you for allowing me to participate, and I'm looking forward to other presentations in this meeting.
Thank you, Dr. Khan, for your excellent presentation. I think we have to leave the question till the end if we still have time. So now we call upon Professor Si Wee Leo from Singapore. She's a senior consultant and medical director for adult and pediatric eye specialist in Singapore. And she's member of the scientific committee of World Society of Pediatric Ophthalmology and Strabismus. And she will talk about update in childhood myopia. Si Wee, thank you.
Good morning. I'm Xiao Wei Liu from Singapore. I would like to thank the organizers for inviting me to give an update on childhood myopia. A typical scenario I see in the clinic is a school-going child with very rapidly progressive myopia, and the parents are extremely worried on how we can control the myopia. I had previously written up about this together with the Scientific Bureau of WSPOS, and this can be found in our consensus statement and current opinions on ophthalmology. Today, I'm going to give a 2021 update. We know that there is a myopia epidemic in urban Asia, which is characterized by increasingly early onset and high myopia progression rates. The earlier the child becomes myopic, the higher the child becomes eventually, and higher the risk of blinding complications. By 2050, half the world will be myopic. To control myopia progression, there are two ways. We need to first slow the onset of myopia and then reduce or prevent myopia progression. There are obvious benefits of myopia control. It gives much better vision, much better surgical correction options, but most importantly, there is reduced risk of visual impairment. We must remember that for every 1 diopter less of finer myopia, it will translate to a 40% less lifetime risk of myopic maculopathy and 20% decrease in visual impairment. When we talk about myopia progression, we are looking at the cycloplegic refraction and the axial length elongation. We do know that it tends to progress faster in younger kids, Asian kids, those in urban environment, and those with family history of myopia. Previously, I looked at this network meta-analysis, which is a way that allows for direct and indirect comparisons of strategies. When you look at refractive error, a positive mean difference means that the intervention is better because there's better control. Whereas for axial length, it's a negative mean difference that we're looking at because it indicates less axial elongation and better myopia control. It is obvious that in 2016, the best results were seen with the atropine studies. To protect against myopia, we need to increase sports hours and outdoor hours. This is seen in the Orinda longitudinal study and the Sydney myopia study. In the Singapore cohort study of risk factors for myopia, total sports hours was significantly negatively associated with myopia. And it's been worked out that there is a 2% reduced odds of myopia per additional hour of time spent outdoors. The protective effect of outdoor time depends on having light of 10,000 lux or more. I would advocate a daily outdoor time of 120 minutes, which translates to a week of 14 hours of outdoor time. Even though the exact underlying mechanism is unclear, you know that time outdoors slows the onset of myopia more than it slows the progression of myopia. As for near work, it's been documented as a risk factor, but the evidence is not totally consistent in all the trials. Recent evidence suggests that the intensity of near work, which means sustained reading at close distance, less than 30 cm with fewer breaks, is more important than total hours of near work in worsening myopia. Atropine eye drops has a long history in myopia control. It is a non-selective muscarinic antagonist. It's been used a lot in Asia since the 1990s. However, its effect on slowing down myopia, that means on myopia control, it is not related to its accommodative effect because it's able to prevent myopia in chicks who have nicotinic receptors rather than muscarinic receptors. So the exact mechanism of atropine in myopia control could be related to neurochemical cascade or direct action on the sclera. There's been a lot of trials on atropine. I'm going to talk about the bigger ones. So the most ATOM 1 was the one that really showed the dramatic result where 1% of atropine once a night in one eye reduced myopia progression by 77% and also did not change the axial length in the atropine group versus the control group, which had an axial length elongation. Atropine was well tolerated with little effect on retinal function shown on multifocal ERG. Of course, with 1% atropine, there's photophobia and from mydriasis and cycloplegia. These effects are totally reversed once the eye drops were stopped. These are patients on atropine 1%. They need photochromatic and progressive additional lenses, but they use it very well. However, there was also a dramatic rebound when the atropine was stopped, with the atropine group having much higher progression of refractive error and axial length elongation. Because of that, we did ATOM 2 to look at the different concentrations of atropine, 0.5, 0.1, and 0.01%. There was a dose response effect, which means that 0.5 worked better than 0.01, with corresponding changes in the axial length. Of note, the 0.01% had actually minimal effect on axial length. If you compare the results of ATOM 1 and 2, you'll find that because it's dose dependent, a lower dose was less effective with like nearly 80% results in 1% with a 60% result in 0.01% in terms of mean change of spherical equivalent. However, with the lower doses, lower concentration, the rebound was less. This means that overall, the atropine lowest dose, 0.01, turns out to be the best because there was less rebound. And it also had negligible effect on accommodation and pupil size with minimal side effects. When we look at the 5-year study, this is divided into 3 phases. In phase 1, it is obvious there's a dose response effect where the myopia was slowed by 80% 1% up to 60% 0.01. However, in phase 2, when you stop the atropine, there was a much greater rebound with the higher concentration and less rebound with the lower concentration. And this anti-myopia effect of the low concentration was maintained very well even in phase 3 after the washout. So this shows that actually 0.01% has the best effect. Now we concentrate on low dose atropine, and trials like the LAMP study done in Hong Kong has also shown good results with other low doses. 0.05% as expected worked better than 0.025 and 0.01% with corresponding axial length changes. There was also minimal effect to pupil size and accommodation loss. As a result, the study concluded that 0.05 was the most effective. Of note, the 0.01% atropine in ATOM 2 study showed a similar anti-myopia effect as 0.05% in LAMP, but a stronger effect than 0.01% in LAMP. It's unclear why 0.01% in LAMP works very badly, possibly because the kids were younger than the ATOM 2 study. In Singapore, we're quite lucky. We have all sorts of concentration in different formulation, both the preserved and preservative-free formulation. As in any intervention, there will be non-response. There's about 12.1% non-responder, and the risk factors are the younger ones, those with higher myopic spherical equivalent, and myopic parents. So I would say that generally atropine eye drops for myopia control is evidence-based. I would use it when there is a rapidly progressive high myopia with a strong family history. I do tell the parents that there's risk of non-responder. I would start off with a low dose, and if they're not responding, then I will increase up. I do not stop abruptly, and I always monitor the axial length. I also tell the parents that different kids may also need different doses or different frequency at different times of their lives. What about lenses, special glasses or special lenses? I would say that generally most of them do not have much effect, except for the newer generation defocus incorporated multi-segment lens with preliminary good results. In chick studies, it was shown that the positive lenses will reduce the growth because myopic defocus inhibit axial elongation. Because of that, it was postulated that in humans, bifocus and multifocus may reduce accommodative demand and retinal focus and hence have effect on myopia control. In actual fact, there was minimal effect with bifocals. And even for the progressive, it slowed the progression of myopia by a small statistical amount that did not warrant any changes in clinical practice. As for monkey studies, they showed that peripheral defocus drives the refractive development. Because of that, there was the hypothesis that hyperopic defocus experienced by the retinal periphery may drive further axial elongation. However, the preliminary peripheral defocus lenses, whether it was the 3 different novel spectacle lens design or myovision or combining a peripheral defocus with progressive air, they did not show any good myopia control effect. More promising results were shown in the recent defocus incorporated multiple segment spectacle lenses. These are lenses with a central distance optical zone with an annular peripheral zone incorporating multiple small segments of positive power of plus 3.5 with the goal of imposing myopic defocus on local peripheral retinal regions. It almost looks like the lens has multiple dimples in the periphery. They showed good control of myopia of about 50%. Of course, 10% may still have poor response and there can be some blur when the child is off center. What about contact lenses? Traditionally, the single vision lenses and RGP lenses have no myopia control effect. There are some soft multifocal contact lenses, some special design ones, which are beginning to show more promising results. There was an extended depth of focus hydrogel contact lens that showed myopia control of 22 to 32%. And more recently, a dual focus myopia control, one-day soft control lenses called MySight showed more than 50% myopia control, about 50% myopia control results, both in the spherical equivalent and axial length. Another popular option is orthokeratology, also known as OK lens or cornea reshaping lens, where the child wears these reverse geometry lenses overnight, and in the day they don't need to wear anything. This is because there's temporary reduction in the myopia by central epithelial thinning, mid-peripheral epithelial and stroma thickening. Quite a lot of trials have been done for ortho-K, and overall, I would say that there's a reduction in axial elongation by 40 to 50%. The younger age group and individuals with larger than average pupil size may have greater effect, but as in other interventions, rebound tends to occur after discontinuation. Obviously, the main advantage of OK lens, besides it's that you don't need to wear any correction in the day, but there are lots of disadvantages. A lot of the studies had a lot of flaws. There was no good control, long-term data, no washout data. There was increased high-order aberrations of the cornea. And the child would complain of reduced visual acuity as the day progresses because there was a natural rebound to its original cornea contour. And of course, there are problems with the lens itself. The most feared is infective keratitis. I have seen cases of pseudomonas and acanthamoeba. Even though the reported rate is about 7.7 cases per 10,000 patients, when you are the patient with the infection post-ortho-K, the vision is invariably very badly affected. These are some clinical pictures of the infective keratitis cases that I've seen from ortho-K prescribed elsewhere. One other popular option these days is combination therapy. Will it work? It was thought that if these different therapies have different mechanisms, it could add on to your anti-myopia effect. So ortho-K and atropine 0.01% has been tried. Even though the preliminary one-year results show that there is less axial elongation, the recent two-year add-on studies did not show any difference in axial length either. So I think we are still not getting that great combination therapy results. To conclude, there are different options for myopia control. Atropine eye drops are very viable options. As for orthokeratology, it has the advantage of eliminating the need for glasses or daytime contact lenses. As for other optical interventions, I would say that the newer, specially designed ones are showing more promising results. In any case, myopia control treatment needs to be continued until the myopia stabilizes, which can go beyond the age of 15 years in 50% of patients. Thank you very much for your attention. I'll be happy to take questions.
Thank you, Dr. Leo, for updating us on recent management of progressive myopia. And now we move to our next speaker for this session, which is Dr. Abir Al-Ali from the UAE. She's gonna give us her perspective about ROP management. So please, Dr. Abir.
Hello, my name is Abir Al-Ali. Today I'll present retinopathy of prematurity in sick and unstable infants. I'd like to acknowledge Dr. Irfan Khan and NICU team at Cornish Hospital. I work in Sheikh Khalifa Medical City, and we cover Cornish neonatal unit. It is a main tertiary neonatal unit in UAE. We screen 20 to 25 babies per week. What is retinopathy of prematurity, ROP? Is a developmental vascular proliferative disorder. It occurs in the retina of preterm infants, leading to incomplete retinal vascularization. Why ROP? ROP is an important cause of severe visual impairment in childhood and can lead to blindness. Now I'll discuss 3 cases of sick and unstable infants who developed ROP. The first case, baby was born at gestational age of 24 weeks. Birth weight was 670 grams. He was the only surviving triplet born by IVF conception. Initial exam showed hazy view, tunica vasculosa lentis. Blood vessels was in zone 1, stage 0. Plan was to watch carefully, follow up weekly. At corrected age of 37 weeks, he developed plus disease, iris rubiosis, zone 1 to 2 with stage 2. And this is the RedCam picture. Plan was to book him for anti-VEGF. I perform injection under aseptic condition. Each eye should be prepped with the bovidine iodine separately. I use 2 completely different surgical sets for each eye. I inject half adult dose. In our center, we use ranizumab. We don't have any financial interest. Injection site 1.7 to 2 millimeter posterior to the limbus, and injection should be vertically oriented parallel to the visual axis to avoid hitting the lens. Also, less than half length of 30 gauge needle should be inserted to the eye. I perform the procedure under local anesthesia and sedation. I follow up the patient after 1 week. I start topical antibiotics 5 times a day. In the follow-up, I look for any signs of infection, cataract, or glaucoma. I look for ROP regression. Also, in the follow-up, I look for any sign of ROP recurrence and activation. Keep in mind, both bevacizumab and ranizumab are off-label for ROP. The difference between two medications, bevacizumab has larger molecular weight and longer half-life and late recurrent 16 weeks post-injection as per BEAT ROP study, while ranibizumab has smaller molecular weight, shorter half-life, and early recurrence 7 weeks post-injection. Both RAINBOW and BEAT ROP trial evaluate anti-VEGF agent. The two studies are not directly comparable. Direct comparison should be approached with caution as the two trials have very different protocols. In RAINBOW study, they include type 1 and zone 2, stage 2. The outcome was towards survival without active ROP or treatment switch, while in BEAT ROP, they involve only zone 1, stage 3, and the main outcome was recurrence of retinal revascularization requiring retreatment. It is very well known that after laser treatment, peripheral retina destroyed, leading to lost visual field. On the other hand, anti-VEGF allows further retinal vascularization. This is the main difference between laser and anti-VEGF. I'll not go into these details. This is same patients 1 week post IVR showed ROP regression and successful treatment. Successful treatment was defined by regression of new vascularization and absence of recurrence. Second case, baby was born 25 gestational age, birth weight was 700 grams. He was the only surviving twins. Initial exam showed hazy view and blood vessels in zone 1 to 2, stage 0. After 3 weeks, he developed plus disease in zone 2 posterior, stage 2, tunica vasculosa, lentis, hazy view. This is the RedCam fundus photo, and the plan was to inject the baby. 1 week post-injection, he had ROP regression, but unfortunately, 6 weeks post-IVR, he developed recurrence of ROP. Laser treatment was performed. This is the same patient. So how can we define ROP recurrence? ROP recurrence was characterized by any worsening sign, including an aggravated ridge or plus disease sign after initial regression of acute phase of ROP. I perform laser under general anesthesia in operating room. I use indirect diode laser with 30 diopter lens, infant eyelid speculum, and scleral depressor. I perform a confluent better laser throughout a vascular retina to ora serrata 360 degree. This is my laser setting. I use power of 150 to 230, and laser burn should be dull white in color. Pulse duration 100 to 200 milliseconds, and burn width should be 0.5 to 1 burn width between each laser spot. This is same patient after 6 weeks post-laser. He achieved spontaneous regression ROP. Last case, baby was born gestational age of 23 weeks, birth weight 500 grams. Baby was sick. Initial exam showed mild tortuous blood vessels, but no dilatation. And the blood vessels was in zone 1 to 2 with stage 1. Plan was for careful watch and follow-up weekly. At corrected age of 34 weeks, he developed plus disease, iris rubiosis, poor pupil dilatation, and plan for injection. 1 week after IVR, he developed complete regression, but unfortunately, 7 weeks post-IVR, he had florid plus disease in zone 2 posterior, very hazy view, poor dilatation. Laser was performed. This is same patients after laser, and he developed complete resolution of ROP. So the question now, which one to use, anti-VEGF or laser? I have no financial interest, but indication of anti-VEGF, we can use it in unstable, sick infants, infant with an inadequate view for laser therapy. It's a good option for posterior disease, zone 1, and aggressive ROP. While laser treatment is a good option for stable infant, zone 2 disease, parents' preference, also is a good option in case of poor compliance with the follow-up, insurance issue after discharge from the NICU, and in our institute, we perform laser after recurrence ROP after anti-VEGF treatment. Keep in mind that if you will use anti-VEGF, there is a risk of recurrence, risk of endophthalmitis, systemic long-term side effect is not known yet. We don't know which dose to use and which anti-VEGF to use. Good option for unstable infants, sick infants, and inadequate view for laser therapy. ROP goals to induce ROP regression and avoid complication. Successful ROP therapy defined as complete regression of active ROP without retinal detachment or distortion of posterior pole anatomy. Expectation of anti-VEGF therapy should be discussed in detail with the patient's family. Infant must be monitored weekly for disease recurrence. Recurrence after ranibizumab occur earlier, 5 to 10 weeks post-injection, versus bevacizumab late recurrence, 16 weeks post-injection. Thank you very much for listening.
Right. Thank you, Dr. Abir, for your talk. Perhaps I think we need to shed some more light about the side effects of anti-VEGF treatment on these preemies. Now we move to our next speaker in this session. Dr. Lionel Cowell from Australia will give us his knowledge about an interesting subject, particularly for strabismologists, that's diplopia in the elderly. So please, Dr. Cowell.
Good morning, Miyako delegates. This is Lionel Cowell from Melbourne, Australia, talking to you about diplopia in the elderly. Two main things I'm going to talk about today: the sagging lateral rectus, also known as the sagging eye syndrome, and anisoconia, both retinal and optical, as a common cause of diplopia after cataract surgery. We are very indebted to Joe Diemer, who recognized and later named the features of sagging eye syndrome some 12 years ago. This offered a mechanical explanation for what were previously considered to be neurological or idiopathic abnormalities. Dr. Gosecki published the first prevalent studies of sagging eye syndrome in Japan and in California, and these are very interesting. We see here that sagging eye syndrome is a cause of about 25% of new cases of diplopia in patients over 60, both in Melbourne, Australia, in Japan, and in California. And the percentages of all the other conditions are all fairly similar. Today I'm going to talk about sagging eye syndrome and a group of other. Sagging eye syndrome has four key features. It is common, It's very under-recognized. It can be suspected on the clinical exam, but it needs to be confirmed with imaging, and I think it's got an unfortunate name. The paper on it is from Dima and Zia Chanduri in 2013, and they pointed out that lateral rectus sag is common in patients with diplopia. Symmetrical lateral rectus sag is associated with esotropia. Asymmetrical lateral rectus sag is associated with cyclovertical strabismus. The pattern of esotropia, distance greater than near, up to about 20 prism diopters for distance, and the vertical up to about 20 prism diopters, and it can resemble supraoblique paresis. The key findings are seen on radiology, where the lateral rectus superrectus band is bowed and the lateral rectus tilts outward. The lateral rectus superrectus band can be disrupted. The lateral rectus tilts outwards and it sags. If the lateral rectus sag is symmetric, we get esotropia, and the symmetry has to be very tight. If the lateral rectus sag is asymmetric, we can get vertical diplopia, and sometimes we get both. So this is a new clinical and radiological syndrome. There are mechanical explanations in the orbit for what were previously considered to be neurological or idiopathic abnormalities. Few radiologists know about this. You, the ophthalmologist, have to look at the films. What was sagging eye syndrome before we knew it was sagging eye syndrome? Long list of labels that today don't really make sense. There is a separate group that I'm not going to talk about today, acquired esotropia in myopes with normal or abnormal radiology, and this deserves another talk. Sagging eye syndrome patients often have exaggerated aging changes, previous facial plastic surgery, etc. Often are using prostaglandins, and indeed prostaglandin-associated periorbitopathy seems to be a common cause of sagging eye syndrome. How do we treat these patients? We treat them with prisms, and if prisms don't work, we treat them with surgery. And there's quite a difference in the need for prisms or surgery in my population as opposed to Los Angeles population, and this difference is yet to be explained. Do all elderly patients with small angle diplopia need imaging? The short answer is yes. The long answer is I don't always image patients who have small angle horizontal or vertical diplopia. If I can easily fix them with prism and they stay okay, if they probably have sagging eye syndrome, for example, if they have the adnexal changes, or if they have non-commutative versions, that's for another talk. And if patients decline imaging, I don't push it, because it's very uncommon with small angle diplopia to find a health-threatening or a life-threatening cause. Are the MRI findings that I've shown you always significant? Well, there are three main MRI findings that are easy to assess: the bowing and the rupture of the lateral rectus superrectus band and the outward tilt of the lateral rectus. And I've shown you those, and they are pre-diplopia changes. When we get a sag of the lateral rectus, that causes diplopia. And here we see from a neuroradiology paper a normal lateral rectus superrectus band, and here we see a stretched bowed band. And this bowing is seen in about 20% of patients under 40 who don't have strabismus, and it nearly doubles by the time we get to 60. So these pre-diplopia changes are seen in a significant minority of normal patients without symptoms. Here is a anatomy lab demonstration of the lateral rectus superior rectus band, the superior rectus pulley, the lateral rectus pulley, the cornea here. It's a substantial structure, even though on an MRI it looks quite flimsy. Are the MRI findings always significant? Can we have these MRI findings in patients who have no symptoms and no strabismus? Well, we don't really know yet, but certainly if the acquired esotropia or acquired vertical is within the motor fusion range, the patient could have no symptoms. I'm going to talk now about another 10% of patients who have diplopia after cataract surgery or who have sensory cause of diplopia. And this is pretty much a 21st century cause of diplopia after cataract surgery. Combination of objectively minor and objectively trivial motor abnormalities with objectively minor and trivial sensory factors that add up to cause diplopia. For example, here we have an 81-year-old patient who developed diplopia after cataract surgery. He's got excellent vision for distance and for near, and unless you specifically ask about difference in image size, you will miss the fact that he has right macropsia. Patients never volunteer that information. And here we have this patient who's got near perfect versions except for LIR under action, trivial vertical forias, trivial horizontal forias, and the main feature is right macropsia. And because of his macropsia, he cannot fuse these very small misalignments. The OCT shows the macropsia, and this patient has macropsia secondary to macular changes. He's still got good monocular acuity. He has very small horizontal and vertical forias that he can no longer fuse because of the macropsia. Giving him a very precise prism, making sure the measurement is precise and the dispensing is precise, allows him to fuse and maintain fusion. And these measurements have to be very precise. Epiretinal membrane surgery often isn't the answer. It can improve acuity, it can improve metamorphopsia, but it tends not to improve anisoconia. Anisoconia can also be due to optical issues, for example, reducing anisometropia or introducing anisometropia. How much anisotropia is it safe to reduce, and how much anisometropia is it safe to introduce? You have to beware of doing this because spectacles often compensate for anisoconia that is due to axial anisometropia better than do IOLs or corneal refractive surgery. For example, this patient who was R-12, L-4, after cataract surgery, if we make him -2 OU, this runs a real risk of producing anisoconia, of producing abnormal binocular vision, and producing permanent troublesome diplopia because of the induced anisoconia plus a small, hitherto asymptomatic and unrecognized foria. There are actually no good prospective studies to guide us how to handle these patients having IOL surgery. So in this group of patients, objectively insignificant, subtle motor, retinal and optical problems can combine to cause abnormal binocular vision and diplopia. Be wary of reducing anisometropia. Be wary of introducing anisometropia. Some patients will have problems, and the percentage of patients increases with time. Thank you very much.
Okay, that was wonderful, Dr. Cowell, because I think this entity, especially the sagging eye syndrome, is a very important one when dealing with elderlies with diplopia, and missing this diagnosis can lead to erroneous treatment as well. So thank you very much. Now, moving to our friend, Dr. Seyhan Özkan from Turkey. She's gonna talk about unusual congenital restrictions. So please, Dr. Özkan, go ahead.
Dear moderator, dear colleagues, this is Seyhan Özkan from Turkey. And I would like to thank for the kind invitation of MEACO 2021 organizing committee for inviting me to speak at this meeting. And I'm going to talk about unusual congenital restrictions, and I'll try to give you some useful tips for diagnosis and management of this problem. I have no potential conflict of interest to disclose. So when we look at the congenital restrictions, the most commonly seen ones are Duane syndrome, Brown syndrome, monocular elevation deficiency, congenital fibrosis of extraocular muscles, and some isolated extraocular muscle fibrosis forms. But there's also another group which is not classified under any of these topics, and these are the ones related to accessory extraocular muscles and bands. And these problems may occur either in combination with the other problems, or they may present as an isolated problem. When we look at the incidence, there is a very nice and very large MRI study about the incidence of such kind of accessory extraocular muscles and bands. And in Kitri and Deemer's study, they have pointed out that in normal population, in 0.8% of the cases, there are some unusual congenital bands. However, in strabismic patients, this incidence increased to 2.4. And in CCDD, this incidence increased to 41.7%. So this is a very significant increase. So considering the surgical findings, many years ago, Goben reported that in Duane syndrome, the incidence of such structures is 34.3%. And in a recent publication, it was reported that again in surgical findings in Duane syndrome cases, the incidence is 48.4%. So when we look at the etiology, these problems may occur as an atavistic muscle, which represents a musculus retractor bulbi remnant, which is a muscle that is present in lower mammals, as these muscles do not usually present in humans. But the muscles that disappear from the creature are called as an atavistic muscle. So these structures may represent extraocular muscle remnants, and they may be either with or without innervation. And they also may represent a component of CCDD. Lueder classified these structures, and he called these as anomalous orbital structures, and he classified them in 3 types. The first one is type 1, and in this case, the structure arises from extraocular muscles. And in type 2, and in this case, they are as distinct fibrotic bands beneath the extraocular muscles. And in type 3, they represent as discrete muscles originating in posterior orbit. So what are the clinical signs that made us to consider that there may be such kind of problems? So the first clinical sign is an unusual motility pattern. And the second one is a globe retraction in unusual gaze positions, very large vertical deviations, elevation deficit worse in abduction, unusual shoots on side gazes, or significant Y or lambda pattern. The surgical signs are unexpected for suction test results during surgery. A positive forced action test after disinsertion of an extraocular muscle also must suggest that the presence of an unusual extraocular muscle or band. Or the other sign is, I call this as scleral fold sign after severing the extraocular muscles, and I'm going to show this. So in the case that I'm going to show you now, when you look at the MRI, there's an accessory muscle or band over the inferior rectus muscle. Here you see that after disinsertion of the inferior rectus muscle, there are some scleral folds. So this is suggestive of a posterior force. And now you can see in this video, we pull the eye and you can see those small plicates, as you can see in the sclera, which is suggestive of a posterior restrictive force. So when we look at the functional and histopathological aspects, we see that accessory bands or muscles cause restrictions. So they limit the ocular rotations. And they may include fibrotic tissue, dense collagen fibers, or muscle fibers. And their innervation is variable, and we have previously demonstrated that these structures may also have paradoxical contraction. So treatment is required if and only if they cause a motility problem. And the treatment is disinserting them or to excise them where possible. And location in posterior globe is, unfortunately, we do not reach to these tissues if it is posterior to the orbit. And the outcome was demonstrated to be unsatisfactory in posterior locations. Here you see a case with bilateral Duane syndrome. And in this child, when we do the bimedial medial rectus recession on both sides, we have seen that after disinserting the medial rectus muscle, the forced action test was still positive. And on both sides, we had these small tissue bands, as you can see here. And after severing those bands, the forced action test became negative. And here you see the postoperative appearance. And this case, again, has a bilateral type 2 Duane syndrome. And he underwent an adjustable lateral rectus recession. And after recession, we have found that the forced action test was still positive. And we realized a small scleral indentation. And you can see the forced action test is positive. And you see this small translucent tissue band. So if you do not pay attention for that, it can easily be overlooked during surgery. And after severing this translucent band, the forced action test became negative during surgery. However, this patient has a recurrent exotropia. So he underwent a right lateral rectus re-recession and left medial rectus resection, and we saw that there was a reattachment of the tissue band during second surgery. So this case demonstrated us that severing of these structures, even though they are small and translucent, may not be enough. So it needs to be preferred to excise them. Here is another case, and this lady has a left vertical Duane syndrome with a significant upshoot on abduction. And she underwent a kinematic MRI examination, and we saw that on horizontal rectus muscles, there was no problem. However, on coronal scan, you can see that on abduction in the superior rectus muscle, there was a paradoxical contraction. So the surgical plan was to recess the superior rectus muscle. However, during surgery, we found that the forced action test was positive on abduction. So because of this finding, we explored the medial rectus area, and we have seen this accessory muscle or tissue band just below the medial rectus muscle area, and histopathology demonstrated no muscle tissue inside. Despite she had a very detailed MRI study before the operation, and the MRI could not show this. However, after seeing this during surgery, our radiologist re-examined the MRI scans, and he found as you can see here, these small tissue bands over there, but these clues are so subtle that he could not make a comment before the surgery whether there was an accessory muscle or not. So here is another case. In this case, there was a tissue band between levator palpebra and superior rectus muscle, and this tissue band was coming on the anterior side toward the limbus. And it caused a significant astigmatic refractive error. And after surgery, after severing this structure, there was no significant improvement on the limitation of the depression, and he did not have a great advantage after surgery. Here is another case. Well, this patient had a significant upshoot in the right eye. As you can see, there's a large vertical deviation on right gaze, and this was in combination with the limitation of depression. And on surgery, he underwent lateral rectus recess and medial rectus resect in combination with imp replacement. And because of the forced action test, we specifically looked for tissue bands, and 2 tissue bands were found. One below the medial rectus muscle, and the other one was nearby the superior oblique muscle. And these tissue bands were excised. And this was how he looked after surgery. As you can see here, the significant upshoot on abduction disappeared on right gaze. And this is another case. Again, she had a vertical retraction syndrome in combination with a Y pattern, as you can see here. And the MRI demonstrated that there was an accessory tissue over the inferior rectus muscle. And on surgery, as this location was too posterior, we could not reach this muscle or tissue band. So only inferior rectus recession was performed. And you can see that both the globe retraction decreased, and also this Y pattern also decreased significantly after surgery. Well, this case has a lambda pattern deviation, and she had a globe retraction on right gaze. And we have conducted a kinematic MRI study for this patient, and the MRI results were quite surprising, because despite she can do a pretty good depression in both eyes, we have seen that there was no inferior rectus muscles in both sides, but instead she had those accessory muscles or tissues below the optic nerve in both sides. And the kinematic MRI result was even more surprising, because this tissue was a real muscle, and it was demonstrating a clear paradoxical contraction on down gaze, and which possibly enhanced the depression despite the absence of inferior rectus muscle. So we decided not to do any operation for this patient. So we did not recess the superior obliques despite this large exodeviation on down gaze, not to decrease the depression. So here is another case, and this child has a bilateral vertical and horizontal divergence. As you can see here, on attempted up and down gaze, both eyes demonstrated a vertical divergence, and she also had synergistic divergence on both sides. And there was a very large exo and a vertical deviation. And the MRI examination demonstrated bilateral medial rectus hypoplasia and right inferior rectus hypoplasia. And on the right side, there was no problem in the superior rectus muscle. However, in the left eye, there was no superior rectus muscle. As you can see here, only the levator muscle could be identified. And there was also bilateral inferior oblique hypoplasia. So on surgery in this child, we have identified 4 accessory muscles. One on the left lateral rectus muscle, and in that case, we have joined these 2 muscles and recessed them together. And the right lateral rectus muscle, this accessory muscle or tissue was excised. And in the right superior rectus muscle, there was 2 accessory muscles, one over the superior rectus muscle and one just under the superior rectus muscle, and they were severed. And she also underwent bilateral lateral rectus recession, right superior rectus and left inferior rectus recession, and this is her appearance on postoperative 6th month. So the take-home messages are: consider accessory muscles or bands in unusual strabismus. Ask for preoperative MRI in suspected cases. Do the forced action test and repeat it after disinsertion and check scleral fold sign. And excise instead of severing, there's a risk of reattachment. And accessory extraocular muscles may have paradoxical contraction, and the target tissue may be inaccessible. I'd like to thank you for your attention, and I'd like to remind you the next ISA meeting, which is going to be held in 2022 in Cancun, and I hope to be able to have a real meeting. Thank you very much.
Thank you very much for a very interesting and informative lecture, actually. Hope to see you in Cancun. Anyway, going to our last but not least, of course, talk in this session. That's my friend Mustafa Mihyar from Jordan. He's going to talk about the consecutive esotropia after surgery for exotropia. So, Dr. Mustafa, please go ahead.
Assalamu alaikum. I would like to thank the organizing committee for inviting me to speak today on the issue of consecutive esotropia after exotropia surgery. Intermittent exotropia is one of the commonest types of strabismus seen in children, and it's classified into basic, divergence excess, and convergence insufficiency. The mainstay of treatment is surgical, and different operations can be used. Most common ones are bilateral lateral rectus recession, unilateral recession resection, and unilateral lateral rectus recession in cases of small angle exotropia. Many surgeons use Park surgical dose tables, which take into account the post-operative exo drift. However, others use augmented recessions, whereby they increase the recession dose by 1 millimeter or increase the measured angle by 5 prism diopters. And the main aim is to try to decrease the recurrence, because with exotropia surgery, the recurrence rate ranges from 20 to 60% according to different studies, and the longer the follow-up, the higher the recurrence rate. So traditionally, a small angle of esotropia after surgery for intermittent exotropia is desirable, and the aim is to try to reduce the recurrence. Several studies showed better long-term outcomes with initial ESO deviation after surgery for intermittent exotropia. I will mention two such studies looking into the amount of deviation on first day post-op and the duration of the ESO deviation. The first published in Eye journal in 2015 divided patients into those who had esotropia for more than 3 weeks and those who had esotropia for less than 3 weeks. In the first group, more than 3 weeks, the recurrence of exotropia occurred in 25%, whereas in the second group, with esotropia less than 3 weeks, exotropia recurred in nearly 60% of patients. The sensory outcome was not affected by the duration of consecutive esotropia in both groups. The second study looked at alignment at day 1 postoperatively and found out that in patients who had overcorrection esotropia and on day 1, the success rate was 95%. In group with orthophoria, the success rate was 77%, and in patients who had exotropia of more than 5 prism diopters on day 1, the success rate was decreased to 25%. So in general, it's better to have initial esotropia immediately after surgery for exotropia, and in most cases, small angle of initial postoperative esodeviation recovers to orthophoria within about 3 weeks. However, it may persist and change into consecutive esotropia. Consecutive esotropia is defined as esotropia of more than 10 prism diopters persisting more than 1 month from the surgery for exotropia. It has an incidence of 6 to 20% depending on different studies. Many predisposing factors were looked into to try to find out which patients will develop consecutive exotropia, including the type of exotropia, type of surgery, age of at surgery, angle of deviation of exotropia, presence of amblyopia, and binocular vision status. And different studies gave conflicting results or different results. One factor which was found to be strongly associated with development of consecutive esotropia is an overcorrection of over 20 prism diopters at post-operative day 1. So if esotropia is desirable and it tends to recover to orthophoria with time, why to worry? Basically, because there are risks associated with consecutive esotropia, especially in young children, and these include developing amblyopia and suppression, losing stereo acuity, diplopia in older patients, and of course, cosmetic appearance. So if we're faced with a patient with esotropia after surgery for exotropia, then one needs to know when is early intervention needed, what non-surgical measures can be taken, and how long to wait before surgery for esotropia. If there is restriction in the movement of lateral rectus muscle on the operated eye and slipped muscle is suspected, then there is no need to wait. Immediate intervention is needed, and patient is taken back to surgery as soon as possible to find out the slipped muscle and reattach it and then treat the esotropia. If this is not the case, then initial management is basically observation. And as we said, in most cases, esotropia tends to recover back to orthophoria within 2 to 3 weeks, even if the initial angle of esotropia was large. If in several weeks there's still esotropia, then full cycloplegic refraction is done, and the full correction of hyperopia is given to decrease the accommodative component. And if there is a high AC to A ratio, then bifocals are given. At the same time, full-time or part-time alternate occlusion may be used to decrease the diplopia and treat amblyopia. If esotropia continues for a month or 2, then base out prism therapy may be used to establish fusion and reduce the angle of esodeviation. If it's a small angle of esotropia, then prisms can be incorporated into the lenses. If it's a larger amount of esotropia, then Fresnel prisms can be used. And patients are followed up over the following few months and gradually trying to decrease the power of the prisms used until the prisms are removed and patients are orthophoric again. And this is usually enough in most of the cases. However, a small percentage will reach surgery, and reoperation is needed in cases of non-acceptance of conservative treatment by the patient, if there is lack of improvement or increase of the basic deviation in spite of prisms, if there is persistence of diplopia because of incompetence, or if there is limitation of ductions. Usually reoperation is reached around 6 to 12 months after the initial surgery for exotropia, depending on the factors above and on the progression of the deviation. If there is slow, steady improvement in the amount of deviation, then one usually waits and gives alignment or recovering to orthophoria a longer chance before operating. The choice of surgery for consecutive esotropia depends on the initial surgery. It can be contralateral recession resection, maybe do a bilateral medial rectus recession, or bilateral lateral rectus advancement. So in summary, immediate esotropia after intermittent exotropia surgery is desirable. It's usually transient, but may persist and turn into consecutive esotropia. Conservative management gives better long-term outcomes, and surgery is better delayed unless a slipped muscle is suspected. Thank you.